short time, about 36 years. Originally as a vascular surgeon, general surgeon, but more recently in administration. But it is coming to an end. It will be at the end of this calendar year, I'll be retired. And torture my poor wife Janice over here. But it's a wonderful place. For those of you that don't know it, we're a medium-sized community hospital, and we do the things that you would expect from a medium-sized suburban community hospital. We deliver a lot of babies, about 2,600 a year, which when Jeb McDonough's father-in-law delivered 17,000 in his career, so we're not quite on that pace, but a lot of surgical procedures, take care of a lot of medical patients. We have a great comprehensive weight loss center, great primary care, great endocrinology. You can hear more about those things. But I do want to thank you for all being here tonight. This is a great way that we can kind of share ideas with members of the community, and I encourage you to keep coming. Thank you.
Thank you. So tonight we are very fortunate. We've got 4 fabulous physicians that will be doing sort of a CNN roundtable chat, so we hope you'll enjoy the format. We have Dr. Dana Desmond-Marcinkowski. She is a family practitioner in Medford, and she cares for patients of all ages, and when she isn't working, she likes to hike and backpack in the White Mountains. Then we have Dr. Karen Wilson. She is the medical director of weight loss at Winchester Hospital and board certified in family medicine as well as obesity. She's passionate about helping all of her patients to achieve healthier lives. When she's not working, she loves to travel with her family, which includes 3 teenagers.
Like is a very strong word, but...
Next, we have Dr. Cecilia Larson, who's new to the Winchester Hospital family. She's an endocrinologist practicing at Montvale Endocrine and Diabetes Center in Stoneham. She's been with us since last February. She is a graduate of Harvard and Columbia College of Physicians and Surgeons, and in her free time, she scrapbooks and plays tennis. Sorry about that. And last but in no way least, we have Dr. Gloria Corda, who is our Chief Medical Officer for Philanthropy and our esteemed moderator for these series. So welcome, and we'll begin the show.
Thank you. Thank you, Denise. So good to be here. So I have some questions, some of which I prepared and some came from you, and you'll have an opportunity if you have additional questions. There's a card for you to write them down, raise it up, and Maria will pick up your cards. So before we get started with questions, just want to ask all 3 of you, what is the role of diabetes plays in your life? How does it come into your practice? Dana, we'll start with you.
Sure. So I'm a primary care doctor in family medicine, so I take care of folks of all ages. So I'm usually the first person that people see when they're hearing about diabetes or when they're worried about diabetes. And obviously with how prevalent it is, it's a massive part of my practice. And I think I spend probably the most time talking to people who are concerned about their risk of developing diabetes and people who are early in their diabetes journey, who are pre-diabetic or have a new diagnosis and just aren't sure what to do with it or where to go from there. And so I see lots of that. I see lots of folks who are struggling to control their diabetes, and I see a lot of people who have had diabetes for many, many years and probably know more about managing it and the right things to do for their bodies than I do. So I see the whole spectrum of it, but it's obviously something that comes into my office certainly every day, many, many times a day.
And Karen?
So at my weight loss program, just like Dana, we see diabetes constantly. I feel like, all I talk about is diabetes. But unlike, I think, Dana, or, a lot of what I do is really try to prevent diabetes and control it. So my favorite part of my day is to actually get rid of diabetes medications or lower their medications. So I feel like I get the fun part of diabetes where they get it under great control, and, we just give lots of praise, and again, my favorite part of my day is just removing medications from patients. So that's great.
And Cecilia, your world involves diabetes as well.
Yes, as an endocrinologist, we have the big three, the triad of diseases. Diabetes, of course, thyroid disease, and osteoporosis, all big players in our current healthcare system. For my diabetes patients, I remind them that their disease never quits, and that it's there with them every day, and that I understand that they have to live with it every single day of their life. And I am trying to coach them and help them to make positive changes in their lives so that they can minimize the adverse consequences of living with such a difficult disease. And I, long before we had a genome that we could sequence, have been practicing individualized medicine, and I think we all have.
Mm-hmm.
We didn't need sequencing to tell us individuals are different. And I work hard with patients to know them and their life, and what matters to them, and what side effects they've experienced on medicines, and how we can, chart a path towards being as healthy as possible for as long as possible. And whether it's diabetes or any of the other conditions that go along with diabetes.
So we call this talk tonight the Great Diabetes Epidemic. Epidemic just means that it's a widespread occurrence of disease. In 1994, the CDC declared that diabetes had reached epidemic proportions and should be considered a major health problem. Cecilia, I'll go back to you. Why do you think this is happening, and can you tell us the difference between type 1 and type 2?
Absolutely. So the majority of diabetes in our country and worldwide is type 2 diabetes. Type 2 diabetes is associated with obesity, and there are many genetic factors that are also associated with type 2 diabetes. Type 2 diabetes, by the time you're diagnosed with diabetes, you already have significant reduction in your ability to process your sugars normally. Some say up to 40% reduction in your ability to process it. And it usually starts with your body being resistant to your own insulin, not responding to the hormone the same way as it used to. And then it progresses over time. Type 1 diabetes is a very different etiology. It's an autoimmune disease where the body attacks the pancreas and destroys it. So it tends to present more cataclysmically and less gradually over time. And when patients have lack of function of their pancreas, they can't make insulin, so they need to be given insulin. So from the very earliest stages of their disease, they become insulin requiring. Both patients with type 1 or type 2 may need insulin as part of their treatment. So that doesn't tell you whether someone is type 1 or type 2. It's usually measuring those antibodies or a few other things. And there are other types of diabetes too, where there are genetic causes that do need a slightly different treatment regimen. So it's important that you get the right diagnosis from as early on as possible.
Okay, thank you. Dana, tell us about screening for diabetes. How do you do it, and who's at risk for developing diabetes?
Sure. So there's different guidelines because every professional organization likes to put their own little spin on who should be screened for diabetes. So I'll say my practice is a mishmash of several of them. So officially, the United States Preventative Service Task Force, very long term for the people who tell me what screening tests benefit which people, says that anybody over the age of 35 who has a BMI over 25, so considered overweight or obese, should be screened sometimes. They don't tell me how often, just that it should happen at some point in their life. The American Diabetes Association says that, and it's similar, any adults with a high BMI or who have additional risk factors should be screened. And so I have a pretty liberal approach to screening for diabetes because I think it's a pretty low risk, high reward. You screen for it, it's generally with a blood test, most commonly the hemoglobin A1C, which I'll talk about at length. I can start talking about it a little bit now. But that is a simple blood test. You don't have to fast for it. It measures essentially the average amount of sugar attached to your red blood cells. So it's a kind of 3-month span of time, the lifespan of a red blood cell. And so it's not affected by if you fasted that day, if you had a big dinner last night, if you went for a run this morning. Doesn't matter, it's your 3-month average. And so that's the most simple screening test, I think. And so I screen a lot of adults for it, and I definitely do screen anyone folks who are overweight or obese, I tend to screen. And then if it's normal, maybe we screen every couple of years. If it's borderline or elevated, we'll repeat it more regularly. Folks with a strong family history of diabetes will screen. Anyone who had gestational diabetes in pregnancy is at higher risk, so we'll screen them more regularly. Certain medications can predispose you to developing diabetes if you're on chronic oral steroids, if you're on a lot of antiretroviral medications for HIV, to an increased risk. Race and ethnicity play a role. Certainly, most folks of color, Latino, Native American, Black folks will all be at higher risk of developing diabetes. You might have a lower threshold to screen. And honestly, I will screen people who ask, who are worried about it, who think that something might be going on. And then not screened, of course, diagnostics is when someone comes in with symptoms and they say, I think I might have diabetes because I'm using the bathroom all of the time, I'm going to the bathroom frequently, and then you're testing to see if that's the actual diagnosis. So yeah, it's pretty widespread, and I tend to, if people, I think, have a lot of risk factors, screen every year. If there's someone who doesn't have a lot of risk factors and they're on the younger side particularly, maybe we'll screen every couple of years, but more frequently say if their habits are changing, if their weight is going up, if they have new diagnoses in the family that again are putting them at higher risk also. So the other piece is if people have other conditions that are associated with diabetes, if you have high cholesterol, high blood pressure, if you've had a history of heart disease, if you've had a history of a stroke, all things that are associated with diabetes, then I'll also be very inclined to screen you.
Okay. Karen, obesity plays a large role in the development of diabetes. How does obesity cause diabetes or the other way around? And can weight loss cure diabetes?
So that's a good question, and I get to talk about my favorite subject, which is obesity. So it's important to know that obesity and diabetes are both chronic diseases, and we have patients who have obesity and they don't have diabetes, and conversely we have patients who have diabetes and they don't have obesity. So they don't necessarily have to come together, but we commonly see them together. But we do know that as the BMI rises, their risk of diabetes increases, and this is primarily due to insulin resistance, which is what Dr. Larson was referring to. And we start seeing signs of insulin resistance years before the patients have overt diabetes, and have to refer to Dr. Larson. So, a little bit about insulin resistance. I know we've all heard about it, but it's really important to understand what it is because this is how obesity is linked. It's usually when the body has a lot of sugar in the bloodstream and the pancreas has to pump more and more insulin in order for the cells to take up that sugar. And what happens, especially with obesity, is that when the body sees a lot more sugar, the insulin, the cells stop responding, right? So they're becoming resistant to it. And the pancreas has to pump more and more and more insulin in order for the cells to respond and take in that sugar. And after a while, the pancreas just kind of can't keep up, and that's when we see those sugar rise. So it's during that time where patients have insulin resistance or pre-diabetes. This is actually when I love to see them at the weight loss center because You know, literally they come in and I get so excited to see them and I say, listen, this is literally what I say, listen, I'm so excited you're here. And they're all like, really? Just my PCP told me to come in. I tell them, I'm so excited that you're here. You have insulin resistance or you have pre-diabetes. It is so easy to treat you right now. Because right now, if you do nothing, that trajectory that you're on, you're going to get diabetes. Whether it's in a year or a couple of years, you're going to get it. So this is the time to treat it. And I tell them it doesn't take a lot to treat. We really always say at Medical Weight Loss, 10%. 10% weight loss actually reverses the insulin resistance. It's amazing. And a lot of my patients come in, they're like, Doc, I need to lose like 60 pounds. Like, what are you talking about 10%? And I tell them, listen, I will show you. And this is one of my favorite things. The patient comes in, they lose 10%, and I get, blood work on them, and I show them, and I say, listen, this is what happened. And I show them that their liver function tests got better, meaning their fatty liver got better, their sugars got better, their blood pressure at this point got better, their cholesterol gets better, and this is just 10% weight loss. It really benefits health-wise 80%. So it really doesn't take a lot. And you can see here, I don't know if Dr. Larson sent this up, but for pre-diabetes, you can see, and this is 2017 data. I actually know this. This is 2017 data. You can see patients with pre-diabetes, 38% of adults have pre-diabetes. And the craziest thing is 65 years and older. If you're 65 years and older, you have, at 2017, you had a 48.8% chance of having pre-diabetes. So that's 1 in 2 patients that we see that are 65 and over that have pre-diabetes. That's a lot of diabetes that we have to treat. So that's why it's so important that we treat it and we treat it quickly, and especially in the insulin-resistant part. In terms of cure, I wish there was a cure. I wish there was a cure for diabetes and obesity. Maybe one day, maybe in 10 years from now, maybe I'll be here, there'll be a pill or probably a fecal transplant that we'll have, and that will cure diabetes and obesity. But right now, we don't have a cure. But we can control it with diet, exercise, and at times medications. And just like Dr. Larson said, these are chronic diseases. And I tell patients that as well. Like, this is for your whole life. You have to continue eating well. You have to continue exercising. You have to continue, taking your pills. Or guess what? Your diabetes is going to get worse. Your obesity is going to get worse. So, it's really important to understand that these are chronic diseases that come together.
Dana, you treat diabetes as a primary care physician. What is your role, and when do you refer to a specialist? And somewhere in there, tell us what an A1C is again. Explain that a little bit more.
Yeah, so the A1C is how we screen for diabetes, but then it's also how we monitor your response to treatment. So again, it's the measure of how much sugar is attached to your red blood cells over the course of 3 months. The range always confuses people, I think. So a normal range, the upper limit of it is 5.6, but it doesn't go down to 0. And I think people always say that they get it back and it's 5.1, and they say, oh gosh, that's awfully close to 5.7. Isn't that too high? And I say, no, really the lowest normal you see is maybe 4.8, 4.7, kind of in that range. So it's a small range of normal, then a small range of pre-diabetes, which is 5.7 to 6.4. And so that's, you don't have diabetes. And I tell my patients that over, and I say, no, there's a big red exclamation next to it on your patient portal, and you're worried about it, and it looks horrifying, but you don't have diabetes. But there's increased risk for it, so you have to, as Karen said, make the changes now, reduce this now so you don't get diabetes. Because if you live at this spot for the rest of your life, you'd be okay. But if it progresses, that's when it's not going to be so okay. And then 6.5 and above is when you have diabetes. And the range from there, the highest A1C I've ever seen was 16, which is much, much, much too high. But generally for folks with diabetes, you want that number to stay under 7. If folks have a lot of other comorbidities or really aggressively reducing their sugar might be dangerous, you might consider under 8 as your goal. But generally around 7 is what you're looking for. So, like I said, I'm usually the person who's diagnosing people's diabetes in the first place. I'm also the person who's catching a lot of the pre-diabetes and insulin resistance and trying to prevent the diabetes from that ever happening. I do a lot of diabetes management in my practice. There's a lot of new medications that if you watch TV, you might see all the cutesy commercials and all the fun jingles for them all over the place. And I'll prescribe a lot of those medications, a lot of the newer ones. And I find they work really, really well, which is great. My threshold for referring to endocrinology has typically been when I need to start insulin. And I haven't had to do that as much recently because all these new medications are really helping me out and making it easier for people to manage their blood sugars and easier for me to get their diabetes under better control. I also will generally refer type 1 diabetics to endocrinology, again, because they always need insulin, and they're often folks who will benefit from the insulin pumps and continuous glucose monitors and all this technology that requires, I think, just more specialization with it to be able to have your patients use it most effectively and get the most benefit out of it. So I'll usually, and then also just sometimes if I don't think people necessarily need insulin, but I'm having trouble getting the right cocktail of medications that works for them, or they have a lot of other medical problems that's making their diabetes somewhat complicated to manage, and I'm not quite sure how to safely manage their diabetes in combination with everything else going on. Then again, I think it's really helpful to have folks see endocrinology and have them support some of those really complicated decision-making pieces.
A member of the audience asked a question specifically about oral meds. Which of the oral meds is sort of the first go-to?
So metformin is usually the go-to medication for everybody. It is old, it is cheap, and it works well. And it has the lovely benefit of, in addition to lowering your sugar nicely, it also has some cardiovascular benefits, meaning that it reduces your risk of having a heart attack or having a stroke, even if it doesn't lower your blood sugar. So even for people who have relatively well-controlled diabetes, who their A1C is 6.8, I'll often still start it at a low dose to try and give them some of that cardiovascular benefit. It helps with some of the insulin resistance. It helps give a little bit of weight loss, which people are usually not terribly opposed to losing 5 or 10 pounds of weight when they're diagnosed with diabetes. So it gives a lot of little bonus benefits in addition to just lowering the sugar itself, which it does do effectively. So if you have, relatively early development of diabetes, your A1C 7.6, often metformin alone will get you, a little bit of lifestyle changes will get you down into an acceptable range. So that's usually the first step in medication. And then some of the older medications that we try and use less now, like the glipizide, glimepiride. Sometimes insurance forces my hand, and that's what we have to use, but they have more risk of low sugar, so we try and stay away from them. I've been using a lot of Jardiance, which is one of the newer medications. Has the cutesy jingles also.
I love it.
Yes, has some benefits for your kidneys if you have diabetic kidney disease, which is always nice. Farxiga is another one that I've been, so I'll try them all. But usually metformin is the starting point because it's cheap, effective, and it does its job.
So Cecilia, with some of the more complex patients, what additional opportunities do they have when they see you?
So what we try to focus on is using the data about these drugs. And just in September, the NIH sponsored a study looking at people who are already on metformin. What's the best next go-to drug? And the data from that study showed that what we used to reach for, those sulfonylureas, the glimepiride, glipizide, have a higher risk of problems like hypoglycemia, even higher risk than using insulin in that study that just was published in September. So we try to avoid that medicine. It's very inexpensive and it's been around. It's the oldest medicine that's been a category of medicine that's been available. And we also look at the patient profile. So if you look at who responds best to metformin, it's actually our younger patients. Older patients don't tend to get as much A1C benefit from metformin as our younger patients. And whether there's weight loss or not weight loss, it is a good drug, and it often should be kept in the mix because it works by its own mechanism, which is different than the other newer drugs. And so when I see a patient, I talk about how the drugs work and why it is I'm not just reaching to get you off of everything, why there's a reason for each of the players in your toolbox that are going to help you with your diabetes control. So there's a role for metformin. The next category of drug that performed the best in that study was the newer agent, the GLP-1 drugs. And that, in the study, was using liraglutide, Victoza, which was an older form of that drug. The ones that you hear about on TV are things like Trulicity and Ozempic in that category. What these drugs do is wonderful. They work by several mechanisms. They actually help with the counter-regulatory hormones that are going to affect your blood sugar. So they help lower some things that tend to work against your insulin. They also affect how full you feel and how quickly the food passes through your intestines. And that has a role because if you gobble down your food really quickly and it moves very quickly through your system, it's going to cause a very high spike in your blood sugar. And some people, that spike lasts for a long time and doesn't come back down. And so how is the pattern of blood sugar? And that's where the wonders of the new technologies that are out there for monitoring our patients with diabetes have been so helpful. The continuous glucose monitoring devices give us real data about where your blood sugar is throughout the day. We can see, and patients can see. It hasn't been widely approved by insurance companies, but if patients can afford to make the copayment necessary to get a continuous glucose monitor, even for a period of time, to use it as a learning tool, it can be so helpful. We can start a new drug, we can start a new diet, we can add exercise, and the patient can watch their sugar over the course of a day and see, boy, I went for a walk. At the end of the walk, my blood sugar was lower, and actually it stayed lower for 3 hours for me. And it's different for each person, the effect of exercise, but it's a consistent effect that it's going to benefit the patient's blood sugars and their lifespan. So exercise is always going to be something that I try to bring up at every visit with my patients. And whatever they can do, it's the same as talking about modest weight loss. You start with the patient where they are. I have someone who's waiting for knee replacements. I said, well, you can do exercises with your arms. Even if you just do this, do jumping jacks in a chair. It's better than sitting still, motionless, in front of a computer. The other medications in the study included insulin. So there were 4 categories of medicines. And the last one was Januvia-type medicines. And like I said, the metformin was already on board. And then what do you reach for now? So that gives us a little bit of guidance. So really what we were thinking, those GLP-1 drugs, the drugs that are going to slow down your emptying and help you process your food better and also are associated with weight loss, tend to be more helpful, whereas the older drugs, like glipizide, which cause weight gain, and low blood sugars, those are real dangerous side effects, very dangerous for a patient whose problem is in part related to their obesity. And those low blood sugars over the long haul, and as the patient gets older, those low blood sugars are a huge risk, a risk of putting them at jeopardy for cardiac events, strokes, and we're even seeing risks for dementia later in life that correlate with the amount of time spent in hypoglycemia. So then we come back to our technology again. We've got these wonderful continuous glucose monitors which can alert you if you're going low. The technology has reached the point that it's predictive. It uses real-time data to predict where your blood sugar will be in the next hour or two and can alert you that you're on the track towards going low and give you an alarm, and then you can act on it and prevent that problem. So it's an exciting time to be in the field of diabetes. It's never exciting to have the diabetes diagnosis, but it's exciting that we have more opportunities and ways to help patients than we used to have.
Okay, that is exciting. And there's a question that came from the audience, there's a couple questions that came from the audience about what a person with diabetes is supposed to be eating. Are there better foods? Are there prohibited foods? Can you tell us about that and maybe talk a little bit about the glycemic index?
Yeah, absolutely. So when patients come to the weight management center, I think they assume that I'm just going to put them on the best diet possible, or I'm going to take all their carbs away. But actually, that's not what we do. There's been thousands of studies exactly asking what is the best diet out there, whether you're diabetic or not. There's got to be an answer, right? And the truth is, there is no best diet out there. It is the diet that you can actually follow, and for the long haul, because again, we're talking about chronic diseases. So commonly patients will come in and they're like, well, I did Weight Watchers and I lost a lot of weight, but then I regained it because I stopped doing it. So that's not the right diet, right? So what we try to do is figure out what diet a patient can actually do for the long haul, as long as it is reasonable. And that's the other thing. There's lots of fad diets out there, and it's really important to make sure that they are following a reasonable diet. They work a lot with our dietitians to figure out what is a diet that they can follow. I say reasonable because when I was a kid, my mom loved the cabbage soup diet. I don't know if anyone has tried that. But I remember every so often my mom would decide to go on a diet and my brother and I would have to eat cabbage soup for a week. So even to this day, I cannot handle cabbage soup. So these are the type of diets that are out there that are not reasonable. Now, in terms of diabetics, again, we do focus a lot on carbs and simple sugars, and we really try to educate our diabetics in understanding how certain foods can increase their sugars and how fast their sugars will increase. This is a lot of times why we need those monitors. So we do focus a lot on carbs, but it doesn't mean that every diabetic can never have a carb. That's not what we're saying. But we just want them to be educated about it. Usually when I see a diabetic, I talk to them about their carbs. I tell them, try to spread your carbs out throughout the day. What we don't want to see is a patient who doesn't eat anything all day and then, comes home from work starving and then eats everything, right? And, we see their insulin just going like this, and then it spikes up exactly, and, then they go to bed. So that's the worst diet. So really, it's really trying to keep your carbs low, but space them out. So, there's many diets out there, but really the most important thing is, a reasonable diet that you can continue to follow long after you've reached your weight loss goal, or long after your hemoglobin A1C, is in that range that you want. In terms of the glycemic index, so I personally don't actually teach that. I don't know if anybody does, but it was an index that was developed in order to teach diabetics exactly that, how different foods affect their blood sugar level. So it's usually a range, it is a range from 0 to 100. 100 is sugar, and everywhere in between is where different foods lie. So foods with low glycemic index, those tend to have lots of fiber and fat, and they raise the blood sugar nice and slowly after eating. Foods that have high glycemic index, they tend to be processed food, white food, simple sugars, and they raise their sugars quite rapidly after eating. So that's kind of how the glycemic index works. The problem with the glycemic index is it doesn't take into account portions, so that's also really important. So it's not just about what you're eating, but how much you're eating.
And I would add, it's about the balance of what you're eating. So when you're having a meal and you're planning your meal, it's about mixing your carbs with your fiber, with your protein, so that you will have a mix of foods that will control your hunger, meet your needs, because we have needs for all of the food groups. We need carbs, we need fats, we need proteins. But it's the right balance of those and at the right time and in the right quantities. So having, a big platter of French fries, yeah, you've got some fat and you've got some carbs there, but that is not the best way to allot your intake of carbs. And so we talk about the plate method and how to make your food colorful, flavorful, and enjoyable, and sustainable. The diet has to be sustainable. Couldn't agree more that it needs to be something that you can live with over the long haul. And it's actually been demonstrated that people who yo-yo then with their diets and weight loss actually make it harder and harder to achieve weight loss the next time you try to restrict things in your diet. And so that is sort of setting yourself up for failure to take that approach. So it is a lifelong approach and building in that exercise component. And again, the technology. So rather than a glycemic index, which is kind of complicated and it's related to some very strict criteria and older studies, I use the continuous glucose monitor or old-fashioned finger stick. And I tell my patient, if you're going to do it with a finger stick, check your sugar right before you have the meal and check it again 2 to 3 hours after the meal. And then learn, how did that meal affect me? And whenever you see a result that puzzles you, write it down right in your journal, what you had, because you're not going to remember. But if you start to journal and write down what the foods are that you're eating and which ones your body doesn't react well to. For some of my patients, the white potato is always the bad guy, and the sweet potato is supposed to be so good. But for some patients, the sweet potato isn't so good. And for some patients, if they make the simple change from white rice to brown rice, they can have a little larger portion without causing as high an elevation in their blood sugar. So you can use either the old-fashioned finger stick or that continuous glucose monitor to help you learn how you respond to the foods that you eat.
Well, it's a good segue to one of the questions from the audience, and I'll read this one. Every Chinese senior I know has high blood sugar. They love rice, cannot stop eating rice. But we've been eating rice for over 5,000 years. Why do the Chinese have such a high rate of diabetes? Anybody want to take a stab at that one?
I'll take a stab.
Okay.
So it depends on where in China, because there are many areas when you talk about Asian Americans versus Asians in Asia. And if you take an Asian who was born in Asia and you transplant them to this country or let them immigrate to this country, the Americanization of their diet increases their risk of diabetes substantially. So because of the other foods and the amount of processed foods in our diet versus what their diet in their native land was by comparison. If you also look, not all populations are the same. If you look at Pacific Islanders, they have a very high rate of diabetes, and it's probably genetic, and in those communities there are probably genes that are predisposing to diabetes in those communities. And in other populations, in Korean, there's also pockets of high rates of diabetes. The rice isn't the bad guy, and the way that we prepared rice 5,000 years ago is different than the way we prepare it now. The processed white rice knocks off the shell, which is where the fiber is around the rice, and that's why brown rice is healthier for you. But you know, that's what many cultures have gone to, is eating the white rice or the processed rice. And that's why we try to say, less processed food is healthier in general. It doesn't mean you can't sometimes have white rice. You certainly can. Or what I do with my own rice is I'll mix it with riced cauliflower, mix it with brown rice, mix it with some quinoa, mixing and, trying to get a variety of flavors and foods that have different kinds of benefit for you. Rice isn't really the bad guy all by itself, but if you eat a whole big bowl of just rice, you are likely to raise your blood sugar and make it more work for your pancreas.
And also, just to add to that, it is true, it's the Americanization. Also, we're not moving, right? No one is walking, everyone is driving, so that's also added to it. And just our portions are much bigger here than elsewhere. When you go to Europe or, Asia, their portions are not out here. You're getting a smaller portion. So much about, it is very true, people come to America and they really do get heavy, and diabetes goes along with it.
So you mentioned physical activity. Dana, could you talk a little bit about what you talk to your patients about physical activity and how exercise is important?
Yes, exercise is the most important, I feel like, for everything. I mean, I tell my patients a little bit jokingly that I think the best medicine in the world is hearing a baby laugh, and second is walking. And it doesn't have to be fancy. Like, I think people sometimes feel like, oh, I don't like the gym, I don't like the equipment, I can't do the gym, I can't run, all these things that are stressful for my body. That's okay. You don't have to do anything really intense. You can walk, and the goal that's put out there and is generally studied and is validated for having the most benefits is 150 minutes a week. And so you can break that up any way that you want to. I think that one of the easiest ways is to do 30 minutes, 5 days a week. And I know that everyone can find 30 minutes, 5 days a week to do some kind of physical activity. And walking, in terms of diabetes reduction, in terms of lowering blood pressure, cholesterol, in terms of improving sleep, improving mood, 30 minutes of walking has just as much benefit as someone who does 30 minutes of marathon training or something much more intense. And there's a lot of physiological reasons for that. As far as diabetes goes, when you're exercising, you're using your muscles. Your muscles need sugar to generate the energy to be able to move. So if you eat a big meal and then you go for a walk afterwards, all that sugar that's floating in your bloodstream, instead of just staying in your bloodstream and circulating, your muscles say, please, give that to me, and they take it up and they turn it into energy. And then because they're being used, they think to themselves, aha, we will need more sugar later because you're using us now, perhaps you'd like to use us again later, and they turn that glucose, the short-term sugar, into glycogen, long-term storage, and so then even more of your sugar is getting taken out of circulation. When you're exercising for a long time, your muscles start to learn, I need sugar a lot of the time because I'm being used, because I'm exercising. They start to become more responsive to insulin, which is telling it to take the sugar in, and they start to develop more receptors to make them more susceptible, to let that sugar in faster and easier. And so over time, you have the short-term benefit of just you eat, you exercise, your sugar's going to go down, and then you have the long-term benefit of over time, your body becomes more responsive to insulin, puts the sugar away much easier, and therefore lowers your A1C. So there's good data that 30 minutes of exercise a day can lower your blood sugar. If you're using the A1C, that measure we talked about, it can come down by about a point with that 150 minutes a week of exercise. And one study doubling that, 300 minutes a week, so an hour, 5 days a week, had an even more significant reduction in sugar. And not just in if you have diabetes, also if you're in that category where you're trying in that pre-diabetic range where you're like, oh no, I don't want to get real diabetes, this is bad enough. Walking does the same thing. It lowers that sugar significantly. And so if you're, some people also are not walkers, and again, I said that's okay. You know, they make those little foot pedals that you can put on your couch and you just sit there and pedal while you're watching TV. Okay, that's something, right? You know, you're going to be sitting there watching TV anyway. That counts. That works. You know, if you're cooking, standing at the stove stirring for half an hour, if you're a baker like me, you know, can you do some little side-to-side steps while you're doing it? And if any of you watched the Great British Baking Show, there's one baker who would do that, and she would get like 30,000 steps in while she was baking because it was just a constant little side-to-side shuffle. And so there you go, you can get that movement in. It doesn't have to be anything intense and difficult. You can fit it into your life in a way that feels joyful and happy and not feeling like this is a punishment. And I know I get you know, of course, walking is not going to give you a big weight loss benefit the way that more intensive exercise will, right? But that's okay, because just focus on the other benefits that it is giving you, on the sugar lowering, on the energy level, on the sleep, on the effects on mood. If it has a big an effect on mood as going to therapy does in many cases. You focus on all of those really big benefits because it makes a huge difference in so many pieces of overall health.
And it actually helps you live longer. Exercise has been shown to add years to people's lives, and it has cardiovascular benefit too, and that's part of how it does it too.
Yeah, I'm a big believer in walking because I always tell patients they don't get injured, right? Keep going. So yes, my biggest losers are my walkers. That's what I say.
Karen, there's a special population where the rate of diabetes is increasing very quickly. Can you tell us about type 2 diabetes in children?
Yes. So in adults, the population that we worry a little bit about is, patients who are about 45 and over. They have obesity and overweight, and they have family history of diabetes. These are, kind of who we look at for the adults. The pediatrics, it's interesting, when I was in medical school or when I was in residency, we never even heard of kids having type 2 diabetes. It didn't even register that that could happen. And now 1 out of 3 children who are diagnosed with diabetes have type 2 diabetes, which is absolutely scary. These are the kids that tend to be in the high ethnicity groups. They have first-degree relatives that have obesity. That have diabetes. They're usually obese. Their mothers usually had gestational diabetes, or they had poor birth weight, very low birth weight. These are the kids that we absolutely have to capture, and we have to screen them early. Because what we worry about is not so much the diabetes, but the complications of diabetes. And we all know that there are complications. Heart disease, vision loss, kidney disease, amputation. And we know that the longer that you live with diabetes, the higher the likelihood that you're going to get these complications. And now we have kids who are getting diabetes in childhood. They're going to be with this disease for much longer than we've ever seen. And so now we're seeing complications for these kids, but at a much earlier rate. They're getting it much younger. It's so important that we are really aggressive with these kids, that we treat them really aggressively to help prevent those complications. So at Winchester Hospital, we have a weight management center, and we see pediatrics. That's probably my passion. And I see kids with insulin resistance, pre-diabetes, as early as 6 years old. These are the kids that we absolutely have to capture and treat. I know one person once asked me, how do we prevent obesity and diabetes? The truth is, in the adult population, we have our noses just barely above water just trying to treat the amount of patients that have diabetes and obesity. We can't even think about preventing it in that population. But in the kids, if we really want to talk about prevention, we have to go to the kids. We have to get them off their tablets. We have to get them out and exercising. It's shocking how many kids just don't even move. We have to get, the most important thing I think is making good fruit, good vegetables, protein at lower costs and accessible to them, and really decreasing the amount of processed food that they have available. If we're really going to talk about preventing diabetes, we have to go to the kids.
You talked a little bit about the long-term complications. There were some questions from the audience asking about the association with diabetes and mental illness, dementia. How does that play into it? Anybody?
So diabetes is a chronic condition, and the rate of mental health issues is higher in patients with diabetes. The more we are learning about mental health needs of the whole population, certainly chronic diseases add to the stress, and you add a disease that affects how you eat, exercise and medications, cost, all those things play a role in that stress factor. Stress also raises your cortisol levels, which also works against your blood sugar and work against your insulin hormone. So they're intertwined, and there are ways that we can see that they're related. And getting proper care for patients who have mental health challenges is very important. You can see it manifest in lots of different ways. Like I said, one of them is stress and anxiety and worrying a lot and not having a way to kind of relax. Obviously, exercise is going to help with that, but I think therapists help too. Sometimes medications are necessary for those conditions as well. The other issues that you mentioned about dementia and Alzheimer's disease, there is a connection, and as I said, right now we're thinking that it is fluctuation in blood sugar, and rapid drops in blood sugar or very high blood sugars for a prolonged period of time do seem to increase your risk of having poor neurologic outcome later in life. And in terms of the mental health benefits, trying to get someone to deal with it, one of the hardest and most challenging patients that I see is a patient who has an eating disorder and diabetes, because managing them requires a lot of understanding and a lot of patience, because they're very smart and they can figure out that if they deprive their body of certain essential nutrients, they might be able to lose weight, but it's not a healthy way of losing weight. And it usually comes at the sacrifice of a higher A1C. By not taking insulin when it's necessary for either type 1 or type 2 diabetes, because they're afraid the insulin will make them gain weight, can be very challenging. Or take a patient who has binge eating, where they might be doing fine, balancing, doing their exercise, but come late at night, watching the game or something, just uncontrollably can eat. There are patients who have nocturnal eating, where they wake up during the middle of the night and they are driven to the refrigerator and eat something. There are some medications that can help with that, and getting them the proper care and plugged in for the management of that aspect of their care is just as important as giving them a prescription for yet another diabetes drug. Because if we don't treat the root issues that are really what the person is struggling with, they're going to continue to struggle and not make the kind of beneficial changes that are sustainable for them and give them a better quality of life and a longer life.
So I'm just going to interrupt. We have about 15 minutes more to go. And so does anyone have questions on their cards in real time? Anybody? You can always raise your hand too. Oh, you got another.
I just wanted to respond to your comments about the animal flavors. You've got rising diabetes in children, which I saw kids with as young as 2 and 3 being diagnosed. In talking about diet, what can we do? Because as a grandparent, I see my children going to public school and getting free lunches, especially since COVID, and they're eating garbage. I mean, I pick my grandkids up, that's my other job. And every day I said, what do you have for lunch? And it wasn't a bagel, it was pizza, it was chicken nuggets, mac and cheese.
Yeah, it's true. I mean, we need to go into our schools, and that's a lot of times where we need to start, because you're right. My kids are also eating just junk. I'm also shocked at what is being served now. I think a lot of how to teach kids is your own, like, right, modeling. So if you're eating healthy, if you're, eating vegetables and fruits and smoothies and everything, I think that does more for kids than just yelling at them to eat their vegetables. So I think modeling is really important, and really accessibility. So in my own fridge, I put a huge fruit bowl in the right there in the fridge, so when they open it up, that's all they see is fruit. So it's making it accessible. I've already washed it for them. I've already cut it up for them. They can't complain, and so they'll just grab it. These are different tricks, but I totally agree. I think we have to go into our schools, and we have to change. It used to be better. It's like these free lunches just became worse. I don't know, something exactly that, right? It's free, it's easy, it's cheap, and this is exactly what we don't want.
I will say, I see a lot of primary care kind of I think it's important to model healthy foods for kids, but I think it's really important to focus on them as healthy and unhealthy, and the healthy and unhealthy behaviors. Because I'm a fairly young woman, I see a lot of women my age, and so many of them have so many body image issues from being told from the time they were a 4-year-old, you're too fat, stop eating that, that's disgusting. And I just see all of these young women in so much distress who can't look at themselves in the mirror. Men too, just their whole lives have been told, you can't have that, you're too fat. And I think that's just such a damaging message for kids' mental health, which is already taking such a big toll. And so I think really important with kids is to not demonize the food, and teach them, this is a bad food, this is an evil food. To teach them that they are not bad if they are overweight, if they're a little chubby. It's not their fault, it's not a personal failing. But just trying to work on, again, the healthy piece. And I talk about this a lot with my adult patients too, because I think everyone has this, tendency to be very negative about their body image and about their weight, and I feel gross, I'm disgusting. And it's your body, it's a wonderful thing. Your body does a lot of great things for you. But yes, the weight can be a danger, but that can't be the only thing that you're thinking about. It's a big piece, but it can't be the only thing. And so teaching kids, okay, we're going to eat this food because how do you feel after you eat a cookie? It's fun for a few seconds, but then an hour later you're crying and you're fussy and you're upset because you had a big sugar crash. But when you eat a piece of fruit, the fruit's also really delicious and you feel happy after eating it, but you feel happy an hour later too. Your body likes that more. And linking the healthy foods to the things they like to do. Well, if you want to be able to go and play soccer with your friends, you have to have some good nutrition in your body so it can be strong enough to play soccer. Don't you want to be able to, run as fast as your big brother can? Okay, well, you need to eat this kind of food to get there. Because I do worry too about so many of my patients I see who have just been given these really hurtful messages about food and body image that stay with them forever. And so it's a very tricky balance for parents and for grandparents to try and educate their kids without creating this really negative and toxic relationship with food for the rest of their lives.
Yeah, I actually completely agree. I think really get weight completely out of the subject. It's not about their weight. It's truly about health. You should not be talking to your kids about their weight at all. Don't even mention it. It's really just talking about healthful eating, healthful lifestyle. And binge eating. We start seeing it, between kids 9 and 14, and it always happens when someone mentions their weight. So really, super duper important. So that's exactly what I was going to say is, please don't focus on weight at all. We're talking about healthful changes.
And I think that's also important when you consider what are your weight loss goals. Since the studies have shown that 7 to 10% weight loss makes a difference, we're not about trying to get everybody to a certain size. That's not what we should be about. And it's, again, comes back to the individual patient and what are your risk factors. If you're overweight and you're exercising and your cholesterol looks good and you don't have a family history of cardiovascular disease and your diabetes tests are turning out fine, then, you know, your weight goal might be different than someone else who carries those risk factors. Well, you know, I've already had one stent, and cancers that are associated with obesity are high in my family. A lot of uterine cancer and breast cancer in my family. So weight loss is an important part of planning for a healthy future. But there isn't an ideal body type or image or size or number at the clothing store that you should be shopping for. Can't agree more with that. People are beautiful in all different ways. Unfortunately, with our society being less active and having more of the processed foods, we are seeing more obesity for the population at large. And if you, the CDC did this years ago, you know, mapped where obesity was, and then if you overlay where is diabetes rising, the two maps are the same. So clearly that is playing a role. But it's also complicated how we're passing it on to the other generations. We've talked a little bit about gestational diabetes and the fact that our parents are having more gestational diabetes. They're sometimes delaying childbearing till later years when the risk of diabetes is higher during the pregnancy. That actually carries an increased risk for the child that's being born to develop diabetes later in their life. So this is an intergenerational compounding effect that we're seeing. And so the answers are going to be complicated ones, but they start with simple approaches. And even if you try with your grandkids when you pick them up to have a fun fruit snack waiting for them in the car and a jug of water, you know, a bottle of water, and then maybe even take them for a walk. Just to try to build in those healthy habits in little ways, fun ways. You know, do a scavenger hunt with them if they're young. You know, take them out on the field and say, how many different kinds of leaves from different trees can we find, or how many different colored leaves can we find? And just making or rake some leaves. I never owned a leaf blower. My leaves came the old-fashioned way. I'm old enough to remember that and shoveled my snow. I don't own a snow blower either. You know, exercise comes in lots of different flavors, and being active and enjoying things. It can be making a snowman, you know, and getting outside and getting off of our electronic devices is really, really important.
So I think we have time for one more question, and then I guess I would ask our speakers if you would just maybe stay for a few minutes if people have individual questions. Gloria, if you wanted to wrap up with one question.
Sure. There are actually these are two quickie medication questions. Why is Ozempic given subcutaneously, and why does it help cardiovascular issues? And why is the cost of insulin so high? These are easy questions. Well, the Ozempic is that's just how it's formulated.
Correct.
There's an oral form very similar, Ribelsis, which is even less likely to be covered by your insurance company. So.
And it's just the delivery mechanism. Ribelsis has a coating that is able to survive the acid in your stomach. So, you know, basically we need to do it subcutaneous because of the acid in the stomach. It has to bypass that.
And the cardiovascular benefit is something we've seen. Do we know why?
Well, it's still being investigated in terms of why, and actually, in that arena, there are, so that's through GLP-1 category drug. And actually, Trulicity has the best data and the best studies demonstrating even primary prevention of cardiovascular events. So that means that if you have no heart disease, but you have diabetes, you're already at 5 times the risk of someone who doesn't have diabetes of having a heart attack or stroke. So you're at increased risk for those things, but you haven't had a heart attack or stroke or a stent or anything so far. Going on those drugs has been demonstrated to reduce your likelihood of having any sort of cardiac event. The second part of that is that the other newer drugs, the Jardiance, has also been shown to have some cardiac benefit in terms of reducing heart failure risk and kidney disease progression.
So it's something we've seen, but we don't know the exact
We don't
mechanism.
know the exact mechanism.
I think there is, weight loss associated with both those medications, so those are also possibly contributing to those benefits that we're seeing, the cardiac, the kidneys, so that might be playing a part in it, but it's true. Like, there's so much about medication, it's interesting where, it's initially, designed for one thing, and then we find out later that, oh, wow, it helps kidney disease, it helps, congestive heart failure. So it's only after a while that we understand, and not necessarily that we understand the mechanism of action, that might not be for years, but, it's just trial and error. When we start getting it to, the millions of people, we're starting to see more and more of the benefit from these medications. There's actually a new medication that came out called Mounjaro. I don't know if everyone has heard about that. It's a new diabetes medication. I feel like these medications are just getting better and better and better, and it's great because when I was studying, there was just insulin and metformin and sulfonylurea, I think, floating around there. So now there's just so many great medications that are coming out, and I think it's just going to explode from here. So it's great stuff happening for diabetes.
And I think you've stumped the panel with the question about why is insulin so expensive, so we're not going to take that one.
Yeah. It's
So,
called
yeah.
Medicare.
First, a huge thank you to all of our speakers. So.